So I did a trial on dual diuretic therapy in the ICU, and we'll start out with a case. So we have a 50-year-old male intubated for pneumonia who's been receiving maintenance fluid for 1 week that we received from an outside hospital. He's on a mechanical ventilator. We're unable to wean him from the vent due to massive volume overload. We start him on Lasix for diuretic therapy, and over 2 days he is diuresed out 4 liters. But at the same time, you notice that his serum sodium has increased to 150 milliequivalents, and you see you calculated his free water deficit, which came out to 3.5, which you ultimately had to replace. So ultimately, this patient's fluid balance ended up being net even. Efforts to diurese has failed, and so you continue to require the same amount of ventilator support. So the question is why? So essentially what we did in this patient with the use of Lasix was we caused them to urinate massive amounts of dilute urine, which ended up leading to massive dehydration and hypernatremia, causing us to replace that free water deficit with free water, so their balance ended up being close to net even, maybe just a little bit of ultimate diuresis volume off. So this phenomenon has been called occult diuretic resistance, when our attempts to diurese patients has typically just ended up causing hypernatremia and dehydration. So we're, again, just reiterating the fact that we're losing free water rather than true isotonic volume. So why is this bad? It increases extracellular volume. I debated this all day actually with some coworkers because we didn't exactly understand this mechanism, but the article explains that without going into too much detail, that because sodium is an extracellular ion, that it through whatever mechanism will increase the extravascular volume, and as a separate note, it's ineffective at improving tissues edema. So essentially what will happen when you diurese out free water, it will remove water in proportion to the size of the compartment that you're removing from. So if you remove a liter of fluid from a patient, about 2/3 will come from the intravascular compartment, and then only 1/3 from the extravascular compartment, which is really our target area in these patient populations. It's also bad because when you cause hypernatremia in these patients, you can cause them to become very agitated. You can imagine being the thirstiest you've ever been in your entire life and sedated on a vent, and you're agitated, and we can misinterpret this as different forms of agitation leading to increased use of sedation and increased vent days. So, and also I thought it was very interesting that, but unsurprising, that hypernatremia is an independent risk factor for mortality in critically ill patients. And so this is kind of how I imagined our patients on the vent when I thought about this. So now I have a lot of sympathy for my hypernatremic patients on the vent, and a little brown hater. So why does this occur in our ICU patients? So what we get is a phenomenon, so avid sodium retention by the kidneys, especially in the distal convoluted tubules. We don't truly understand why this happens. We think it has something to do with a lot of our population uses chronic Lasix, and there's remodeling by the actual nephron itself, but there's also association with the activation of the RAS system and dopamine effects in the distal convoluted tubules. So this in combination with the fact that furosemide only blocks reabsorption in the descending loop of Henle leads to this phenomenon where we get a lot of free water loss rather than true isotonic volume. So what is the proposed way to combat this occult diuretic resistance? So this is an article sought out to add thiazide diuretics. So not only will we work in the loop of Henle to decrease reabsorption of sodium, but will also work in the distal convoluted tubules. So our ultimate goal is to have, of this combination therapy, is to have balanced excretion and a urine that is closer to serum electrolyte balance. And so essentially the idea is that we'll pull more from the extravascular space rather than the intravascular space. The evidence. So, so this is the article. And then, so this was essentially a prospective RCT with 40 volume over patients in the ICU. They heavily excluded heart failure, anybody who used chronic diuretics, advanced renal failure, and anyone who had received furosemide during their hospital stay. They randomized them into two groups, one receiving the furosemide only, and the second group receiving the additional of the thiazide, and they were monitored over 24 hours. So the major takeaways with this trial is that we saw a much greater net negative in sodium loss. Surprisingly, they had a pretty similar, there's essentially no difference in actual volume removed. But unfortunately, in the group that only received Lasix, they had an increase in serum sodium, which obviously later on leads to increase giving back free water. And then they had in the furosemide plus the thiazide, we had a statistically significant decrease in pedal edema or peripheral edema scores. So this is just a recap again. There was no difference in urine output. But with the addition of the thiazide, you saw greater natriuresis and sodium balance and decreased peripheral edema. So the idea is that not only are you diuresing free water, but you're also diuresing out sodium as well. So the limitations of the study was that it was non-blinded. However, most of the scores were objective findings, so I'm not sure how much of a limitation that was. It was a single center and it was a small population. And then they only examined the natriuresis over 24 hours. And they had a pretty comprehensive exclusion criteria, which means that the external validity can be pretty questioned. And we would need to study the applicability of this use of these dual diuretic therapies on more patients. So the future of this, which I thought about as well. So there's 4 places that we can prevent the reabsorption from sodium from the nephron. So as a result, there are additional studies that have looked to add spironolactone, which will actually Lasix and thiazides like to also give you lose potassium. So the additional spironolactone will also help us to combat that complication from that. So that's in the process. And then obviously, then we go ahead and take on the last area of the tubule, the nephron, with the additional amnophyline. So, sorry, that was very fast. Does anybody have any questions?
Discuss it.
Let's go 5 at Samska.
Timing. Does timing matter?
Timing?
Yeah, thiazide, and then 45 minutes, an hour later, give the lube.
They gave them at the same time. Yeah. So it wasn't like a tapered. And like I said in the limitations, they only trialed 1 dose. So different doses may have an effect on the diuresis effect as well.
Was there any increased risk or increase in AKIs or chronic kidney disease using more diuretics?
So actually, the dual diuretic therapy improved creatinine clearance. So while they didn't mention anything with an increase in acute kidney injury, I would actually assume that if you were dehydrating your intravascular compartment, that you would have some prerenal dysfunction. So I'm sure that they did see that, but they only really commented on the fact that they had improved creatinine clearance with the the dual diuretic therapy. So I think that that's actually a pretty big component as well.
Did they exclude patients with renal injury prior to the diuresis?
Yes. So anybody who had who had greater than a 1.8 creatinine were excluded.
Can we go back to that exclusion slide? CHF, diuretics, chronic kidney disease.
Yeah.
Y'all gonna start incorporating this into your practice? Anybody?
I'd just say in general, without having read the study, great presentation by the way, there's so many, and you alluded to this basically, the idea that there's so many different mechanisms reasons why people that we see in the ICU might have disorders of water and sodium balance. And then you alluded to that the exclusion criteria were really pretty stringent in this small study, suggesting that they're really narrowing in on one particular subset of patients with the characteristics that they wanted to study with this mechanism. So my takeaway would be, before I would recommend or support widespread adoption of this method of treatment, make sure that we understand what the patient in front of us has going on relative to what this trial and other studies and editorials on sodium and water imbalances tell us to do.
Yeah.
I think something interesting, I was more cognizant of my patient's sodium last week when I worked, and I think we sometimes become numb to these hypernatremia because we see these patients that are like 175 every now and then. So you see a 155 and you're like, oh, maybe that's not a big deal. Maybe it's affecting our patients more than we think. And if they're delirious on the vent, we can't get them off. Maybe it's not just the sedatives they're on. Maybe if we corrected their hypernatremia a little better, we get better results.
I agree with Dr. Patterson's comments. I would add, though, it didn't show any harm. It had some soft primary endpoints. We didn't show any improvement in mortality or mental reduction or any improvement in renal rates of renal failure from that. But if your goal is better sodium control, which I think is important, it may be something to use if we see for diuresis in the patient and when we see the sodium starting to climb, adding this therapy. And I would object with trying that in patients, even in the face of CHF or acute kidney injury.
I think it's also helpful that it actually will decrease our peripheral edema. We constantly look at these patients over and over, and we contemplate their intravascular space versus their extravascular overload. So if this method is suggesting that we can maybe actually diurese more from the extravascular rather than just more from the intravascular, then that would be something definitely to consider. I think that that's something we battle all the time.
One of my favorite things about this article was how the Australians spell diuresis.
That's true.
It's real hard-hitting, cutting-edge analysis.
Is there any data behind the strategy of using 25% albumin to draw more of that extracellular water into the intravascular space? Because I see it all the time.
Right.
But I didn't know if that changed the balance.
That's very interesting that you mentioned that. Paige was talking to me about, so her original, you were thinking about doing Lasix or albumin Lasix trial, and that there's more trials that suggest that it does not work, and then there's one ambiguous trial that suggests it may work. So we have no evidence.
Okay,
Is that what essentially what you told me? Yeah.